I'm Chris Young, I'm a cardiac surgeon here at St Thomas's, and I'm also the chair of Heart Valve Voice. And Heart Valve Voice is a charity for people, for doctors, for carers, for relatives. It's involved with all aspects of heart valve disease, and we want to be there for you. And what we try and do is get involved at government and at decision levels and with NICE. We want to get involved with the clinicians, with both general practice clinicians and also with hospital clinicians, to try and make sure that there's an even playing field for all patients who have heart valve disease. From the point of view of the patients themselves, we want to be there as an educational facility. We want them to be able to have confidence in what they're about to face through the education and the support that we can give them, which is principally through the website. And finally, we're there for relatives, for carers, even for the children of people with heart valve disease, so that we can help them to manage their way through what should, from our point of view, be a very straightforward procedure in the main. So this video is designed for patients who are awaiting treatment for their heart valve disease, and also for patients who have already had treatment but are worried about what the COVID pandemic means for them at the current time. So what I'm going to be doing is interviewing two doctors, two clinicians, to get their take on how COVID is affecting their practice. The first one will be an interventional cardiologist, Dr. Douglas or Dougie Muir from Teesside, and he will be giving us the hospital view. And on the other side will be Dr. Chris Arden. Chris is a GP with a specialist interest in cardiology. So I want to start by asking both of these doctors separately about the effect that the COVID crisis has had on their departments. We know that appointments are being cancelled, a lot of consultations are being done by telephone, and I want to know how these changes have affected practice, and particularly thinking about it from a patient's point of view, because they must be so worried now. So let me start first with Dougie. Dougie, can you explain really how the current crisis is affecting your department in particular in cardiology?
Good morning, Chris, and many thanks for asking me to take part in this important discussion about cardiac care during the COVID crisis. It's certainly true to say that our hospital, in common with many others, has seen quite a large increase in admissions related to COVID illnesses and respiratory problems. But the hospital, in common with many others, has made quite a lot of changes to allow us to cope with this. So, for example, in our hospital, we have segregated the hospital into two distinct departments, one of which is for patients who have been managed for COVID or have been suspected to have this condition, and then the remainder of the hospital is largely been kept separately running to allow us to continue to treat patients with other non-COVID related conditions. Importantly for patients, it's really key to note that all emergency care is continuing, and the reason we've been able to maintain that is by reducing and in some cases suspending services for more minor or less urgent conditions. So that means that we do have capacity to treat emergency cardiac problems in particular, and patients should really bear that in mind when they're considering whether to attend hospital.
Thanks, Dougie. And I agree, it really is important that patients should understand and know that the NHS is there for them, that treatment is still available, and that they should have confidence in the NHS. So let's switch to Chris. Chris, tell me, in general practice, how has the situation been affected for you?
Thanks, Chris. With regards to how our current practice is managing the COVID situation, certainly we're doing a different type of consultation. We'd encourage patients to continue to monitor symptoms, and if they feel they've got any significant change, that they contact us, and then we'll arrange either a telephone consultation and, if necessary, a face-to-face consultation at the surgery.
Thank you, Chris. I think patients should take a lot of comfort in hearing how you are able to cope and manage and look after their disease throughout this time of crisis. So as the number of cases increases, we find increasingly that patients are self-isolating. They want to shield themselves and they're moving away from the hospital environment. They're not keen to come up, they're worried they may catch something. And so what I want to know is how the medical profession is handling this as they get further and further away from the interface between doctor and patient. So Dougie, what changes have you made in your practice and in the hospital practice to cope with this and to maintain the level of service that you'd be happy with?
Chris, that's an important point, I think, about patients being wary of attending hospital appointments. And of course that's appropriate because we do want to maintain social distancing, but we have to strike a balance. So we have had to make some changes to how we run our services in response to this. Perhaps the most obvious change is that we are trying to minimise face-to-face clinic appointments for routine follow-up. So for example, in patients with heart valve disease, they'll often come to see us perhaps once a year with a clinical examination and a discussion and perhaps an echocardiogram. At the moment we are suspending most of these routinely but replacing them with a telephone contact. Now that's quite important because actually, although we do rely on our scans and in examining patients to some degree, by far the most relevant pointer that we have as clinicians to recognise when a patient's condition is changing is their symptoms. So if a patient comes into clinic and tells you they're feeling very well with no change in their symptoms since you last saw them, that's highly reassuring regardless of what the scan might say in the vast majority of conditions. So what that means is that you can quite easily replace a face-to-face consultation with a telephone call. And if the patient tells you that they're well with no increase in, for example, breathlessness or chest discomfort or other similar symptoms, that's highly reassuring. And we can generally be quite comfortable that a face-to-face appointment at that time is not required and thus maintain social distancing. However, there are some patients whose symptoms are changing and we do want to know about that, and in many cases we do want to follow that up with a face-to-face consultation and perhaps an up-to-date echocardiogram. When the patients come to hospital, they can still be protected because, as I mentioned earlier on, the COVID patients are held together in the same area so that they are kept separate from the remainder of the hospital. Secondly, all of the staff will be equipped with appropriate PPE, meaning aprons and gloves and face masks, and that's to protect both the staff and the patients. We've been a bit worried that there's a slight message that some patients are staying at home or not asking for help from healthcare professionals when their symptoms are changing, and I think one of the key messages to give patients is that they know very well what their body is telling them, and if they feel a change in their symptoms, that shouldn't be ignored, and appropriate contact should be made either through the GP or through the heart valve clinic.
So now I want to move to Chris Arden. Chris, you really are at the sharp end of this. The patient-doctor interface comes through you first of all. Can you tell us what changes you've made in your practice to accommodate the problems that are going on at the moment?
With regards to changes that we have made in terms of our working practice in the current crisis, there have been a number of changes that we've made from an operational point of view. We're certainly triaging all calls before patients visit the surgery, and when they come to the surgery there's appropriate social distancing, and we're keeping the front door locked so there's no walk-in patients attending the surgery. But again, I must emphasise the point that we're very happy and keen to see patients, but they will probably need to be triaged on the phone before we see them face to face in the surgery. When patients attend the surgery, we're all using and wearing appropriate protective equipment known as PPE, so don't be surprised if you see either the GP or the nurse wearing a gown, face mask and gloves. This is as much to protect yourself as the healthcare practitioner. And certainly we'd encourage patients to continue to monitor their symptoms and also observations including blood pressure, pulse, heart rate, potentially weight, so any sort of rapid changes in weight may be reflective of changes in terms of fluid balance and fluid congestion. So it's important that patients do monitor these symptoms and share them with us when we triage them over the telephone.
So I think what's worrying us all medically is the number of presentations both to GPs and to hospitals has reduced dramatically, and yet we know the disease is still out there. And I think partly because patients are shielding themselves away and staying indoors, they're not necessarily experiencing the symptoms they used to get when they went outdoors and they walked, and it's masking the problem developing. And I think the message that you need to take away is both GP practices with the likes of Dr. Chris Arden and also the hospitals are fully able to cope with patients who deteriorate. And already plans are coming into place so that we can manage to pick up the reins again and start treating those patients who we've delayed because of the sudden influx of patients with COVID. So we're getting daily statements, we've got scientific advisors on the television, and a lot of what they say is not necessarily written or spoken in absolute plain language for people to pick up. And we see official statements, and sometimes they too are written in a way that you almost have to understand the disease to know what's going on. But so what I want to do now is ask these two doctors to explain in very straightforward terms what are you advising your patients if they notice a deterioration in their symptoms, or if their relatives notice that they're not as well as they used to be. So let's start with you, Dougie.
I think, Chris, the most important bit about patient contacting healthcare professionals is that they speak to someone. In many ways it doesn't matter who the first contact is, because if they turn out to have gone in the wrong direction, they can be redirected quite readily. But the most obvious protocol might depend on what stage they are in their condition. So for example, a patient who's under routine follow-up for a mild or moderate valve leak, in whom they are not at the stage of requiring any intervention, but they develop symptoms, then their first port of call should probably be their GP or practice nurse. Because a change in, for example, breathlessness may be related to their heart problem but could have other causes, and the appropriate investigations can be directed through primary care in the first instance. If, on the other hand, a patient is already at the stage where their valve disease is requiring intervention by either surgery or some other means, that's probably quite different. And if those patients are already waiting for a procedure and the heart valve team has decided with the patient that that's the appropriate way forward, and those patients deteriorate, then probably it's more important that they speak to the heart valve team directly. In our hospital, for example, I'm involved with the TAVI service, which is a means of replacing aortic valves without open heart surgery. And we have a TAVI nurse and a TAVI coordinator, and all of the patients on our waiting list are well advised of their contact details and who to speak to if there's a problem. And we have a very fortunate situation where we can have the phone line manned all 7 days of the week, and we can return calls if necessary. And in that way we can make sure that if we have a patient on the waiting list who is getting worse, we can arrange to see them or bring their treatment forward if required. I think the key thing is that we don't want patients to miss the opportunity to have their valve treated if it's at the stage where otherwise we would be considering operations or intervention. Patients are sometimes worried that they're taking up NHS care and thereby depriving patients with Covid-19 of the appropriate therapy, but that's definitely not the case. There is capacity for treating patients with important and serious cardiac conditions, and what we desperately want to avoid is the situation where, at the expense of treating COVID patients, we don't treat our patients with completely treatable and in some cases curable heart valve conditions, and have a second group of patients who are suffering from this terrible pandemic.
With regards to who patients should be contacting in the event that they feel that their symptoms have changed or are deteriorating, first point of contact should always be your general practitioner in the primary care setting, or if you do have contacts with the hospital, then through the appropriate clinic. Although face-to-face contacts may be reduced, we're still here for telephone advice and review as appropriate. My advice to my patients is to use this symptom tracker regularly, and if they have any concerns in terms of changing symptoms, to contact us directly for further advice.
Thank you both for that, and what I want to do now is to move on to my final question, and really the question is about what happens when there's light at the end of the tunnel. So I want to ask you both separately what you have in place, what plans you're coming up with to manage almost the deluge of patients that will be there once COVID perhaps not goes away but dies back, so that we can get back to a normal practice. So Dougie, what are you doing to try and make sure you're going to be able to cater for what could be a large influx of patients when the wards finally open again normally?
Well, Chris, I think resuming services after the COVID outbreak subsides is undoubtedly going to be a challenge. But I think that the governmental policy on social distancing, etc., is likely to not halt abruptly, but to phase its way out. And I think we will see something similar but opposite in the hospital, in the sense that we will be phasing our services back in. So rather than going from a completely switched off service to a 100% switched on service, I think we'll be bringing certain parts of the service in stage at a time, with the priority being the patients that are at the highest risk of harm if they are left alone. We already have plans for that in hand, and for example in our TAVI service we are already bringing in right now our very highest risk elective patients. So these are non-emergency patients, but patients who we are concerned about because their heart function is struggling or their symptoms are deteriorating, and we're already bringing some of those patients in on a case-by-case basis to phase in a resumption of services. But I think it is true to say that patients are likely to wait longer for some of their appointments, but hospital services are already very well used to stratifying patients' risk. In other words, identifying which patients are at the very highest risk and treating those patients with the highest degree of priority to prevent harm. One other interesting thing that has just struck me is that our telephone clinics have actually been pretty well received by patients, and a lot of the patients have given us very positive feedback. So it may be that in conjunction with patient groups and institutions like Heart Valve Voice, if patients think this is a favourable way forward, it may well be that in the future, unrelated to COVID, then some of our patient visits can be replaced in part by some telephone conversations or use of video links, for example, when patients are comfortable with that. So this is something that has been an unexpected offshoot of this crisis, which I think is potentially quite interesting for the future, and something that we will probably want to explore further with patients and patient groups.
I think the message that we're getting from that is that patients should take comfort from the fact that they're not being forgotten. we all care incredibly about how they're treated, about when they're treated, about getting the best for them. And the system is such that we have things in place that will look after you. For the moment, it may be the more urgent cases we're doing, but I think very soon we'll be able to widen the healthcare, widen the interventions, so that all patients who need interventions, who need valve replacements, who need valve repairs, will be able to get it done in a safe environment. And now moving to you, Chris Arden. How do you think that not the end of COVID, but as COVID dies back, is going to change your practice? Do you think there will be a large influx of patients who have been too scared maybe to come? And if that is the case, how are you going to be able to prioritise to see cardiac cases, particularly heart valve cases, which can sometimes be on such a knife edge?
With regard to supporting and managing our patients once this immediate crisis is over, we do recognise that it will be a significant challenge both for primary and secondary care to provide patients with ongoing support. Within primary care, we'll endeavour to have our usual face-to-face clinics up and running as soon as possible, supplemented by appropriate video and telephone triage. We'll also be continuing with social distancing measures as recommended by Public Health England. We will continue to work within whatever precautionary measures are advised in order to make sure that our patients are managed safely. Our patients certainly remain our first priority, and their care will always be paramount, and we'll endeavour to continue to deliver the best care possible in the community.
And with that, I think our discussion is over. I want to thank you both gentlemen for the contribution you've made, for us being able to hear your insights, and also thank you for all the hard work that you're undertaking at this time to look after the best interests of your patients.
Thanks very much, Chris, for chairing this morning, and thanks to Heart Valve Voice for inviting me to take part in this important discussion. If there are any questions subsequent to our discussion today that anyone wants to ask, please forward them to Heart Valve Voice, and we'll do our very best to answer them for you.
Many thanks for chairing this session, Chris, and congratulations to Heart Valve Voice for the innovative way they've been able to share this helpful information with our patients. Thank you.
So in closing, I'd like to stress that Heart Valve Voice is there for you. If you have queries, please feel free to contact us. The answers we give may actually be quite general because we don't know your specific case. And finally, I'd like to stress really that heart valve patients, your voices are being heard. The medical community is doing all it can to get back to a normal way of operating, to cater for the needs of all of you, that there are systems in place that will try and pick up patients who are deteriorating to try and expedite their treatment. The healthcare workers are really working tremendously hard for you, and we are there to lobby for you, to try and make sure that this gets back to normal as quickly as possible, and to be there for you if you need us.